السلام عليكم. الحقيقة I have a great pleasure إن أنا أبقى واحدة من الشير بيرسونز. أولاً وجودي وسط أساتذتي طبعاً دكتور هشام ودكتور علياء قطبي اللي هم يعني علموني أوائل النيوناتولوجي والكارديولوجي من سنة 90 لغاية يمكن 2000 وشوية، وما زالوا مصدر إلهام وعلم ونور. الحقيقة أنا again very pleased إن احنا نختم المؤتمر الجميل الرائع ده بسيشنز مهمة جدا، وهي النيوناتال hemodynamics. فالend result for any sick newborns في الآخر either إن هو هيجيله pulmonary hypertension with hypoxic respiratory failure أو إنه هيجيله shock. والclue for the right management إن احنا يبقى عندنا understanding of what's actually happening. ويمكن زي ما قال الدكتور علياء، لو أنت عارف الdiagnosis أو أنت عارف if you have the knowledge العيان ده مش هيموت. فالعيان shouldn't die because we should have the understanding, the in-depth understanding للpathophysiology والhemodynamics. الحقيقة our first speaker, we have two eminent speakers today. The lectures will be recorded, but then they will join live with us to answer your questions. So please, as the both lectures flow, write every question, try to ask questions. وبالنسبة للشباب الصغير, please don't hesitate to ask any question. مفيش سؤال غلط، مفيش سؤال ساذج، مفيش سؤال دمه تقيل، كل الأسئلة valid. This is your time and your right to ask questions. The first speaker will be Yasser. وياسر الحقيقة يعني consider one of يمكن the new legends في neonatal hemodynamics والneonatology in general. هو مصري، اتخرج من مصر وعمل training in pediatrics في مصر وكارديولوجي كمان، وبعدين he went to Manitoba عمل neonatal fellowship، وبعدين advanced neonatal echo and hemodynamics في Toronto sick kids. And after that he became neonatologist, one of the leads يمكن في العالم دلوقتي في ال point of care ultrasound وال neonatal hemodynamics، وهو اللي established neonatal hemodynamic assessment unit في مانيتوبا. والحقيقة هم enlightening العالم كله. أنا I wish this opportunity في وجودي مع أستاذتي الدكتورة علياء إن إحنا كمان في مصر ودكتور هشام it's the time really إن إحنا كمان يبقى عندنا team dedicated to the neonatal hemodynamics. ياسر في last 5 years دكتور ياسر already published more than 100 articles و they are all يعني very very important for us to learn from. وكمان عمل يمكن more than 100 workshops all over the world، وهو is willing إن شاء الله إن هو يعمل لنا high fidelity simulation workshop إن شاء الله in the coming few months في congenital diaphragmatic hernia management. So welcome Dr. Yasser. We are going to watch the lecture about understanding the pathophysiology, the physiological approach to manage neonatal shock. Thank you very much.
Welcome everyone, and thank you for the kind invitation. I will discuss today physiologic-based management of shock. I have nothing to disclose in this presentation. And I have 4 main objectives to discuss over the next 20 minutes. At the end of this presentation, the attendees will be able to, first, demonstrate physiologic determinants of cardiovascular performance, demonstrate physiologic categories of hemodynamic instability, differentiate the common neonatal diseases associated with hemodynamic instability, and then at the end, we'll be able to select the logical cardiovascular support according to the underlying pathophysiologic mechanism. Before we start, we need to understand 4 important definitions. First, oxygen delivery, which is the amount of oxygen delivered per minute at the tissue level. It depends on 3 important components: steady blood flow, adequate hemoglobin content, and the hemoglobin saturation with oxygen. And we need to understand that the most important goal to maintain hemodynamics is to maintain at the end normal oxygen delivery. Then hemodynamic instability. Hemodynamic instability is a fluctuation of any one of the hemodynamic markers, which could be blood pressure or any other markers like peripheral perfusion or heart rate. This fluctuation may or may not affect the blood flow at the end, and hence oxygen delivery, because it might be compensated by autoregulatory mechanisms. And then hypotension. Hypotension or low blood pressure should not be used synonymously with shock. Blood pressure is one of the hemodynamic markers that may or may not be associated with decreased blood flow, and hence shock. And then shock, which is a state of imbalance between oxygen delivery and oxygen requirement at the tissue level. So the body autoregulatory mechanisms will try to compensate and to maintain normal oxygen delivery to maintain demand. But once the oxygen demand exceeding the delivery, then the anaerobic metabolism will take over and the autoregulatory mechanism will be compromised or exhausted. Now let us understand first the compensatory mechanisms one by one. With any kind of hemodynamic instability due to hypotension, tachycardia, delayed capillary refill, or worsening perfusion, the first compensatory mechanism is autoregulation, which is release of nitric oxide through RBCs at the tissue level. With this nitric oxide, the local vasodilation will try to maintain more blood flow. And at this stage, everything is still compensated and there is no any significant decrease in the oxygen delivery. But once autoregulation compromised, the tissues will try to compensate for the decreased oxygen delivery by increasing extraction, and this increased extraction might be detected on near field spectroscopy if you have this technology. And once the extraction increased, it means that the autoregulation has been compromised. Then if the extraction reached the maximum and there is no more capacity for the tissues to extract, then anaerobic metabolism will be the next compensatory mechanism with increased lactic acid. At this stage, the consumption will be decreased. At the end, the lactic acid also will be decreased with tissue necrosis and worsening of organ functions, and then we may have irreversible shock and death, which is definitely decompensated stage. We have 6 main physiologic factors affecting blood flow: preload, afterload, myocardial performance, heart rate, persistence of fetal shunts, and vascular tone. First, preload, which is the most important factor, it refers to volume of blood present in the ventricle at the end of diastole. So typically it is the added volume of blood from the venous return to the right atrium from the systemic circulation and to the left atrium from pulmonary circulation, and this extra volume will be added to the whatever remaining in the heart at the end of systole. But because of the volume is really small, the left ventricle and right ventricle will try to evacuate and eject most of the blood, and will be very small volume remaining at the end of systole, or maybe no blood at all. We have 3 main factors affecting preload: the pulmonary vascular resistance. If the vascular resistance is high, then the venous return to the left atrium will be less than expected, and also the intravascular blood volume, the overall body intravascular volume, and also the diastolic compliance of the heart. The main compensatory mechanism for decreased preload, the body will try to compensate by increasing the systemic vascular resistance to maintain the blood flow or the blood pressure. As we can see here in this parasternal long axis view, the left ventricle is almost empty at the end of systole due to significant decreased the end diastolic volume. Then the second physiologic factor is increased afterload. So if the left ventricle contracts against significant vasoconstriction, then the performance of the left ventricle is expected to be impaired, or contraction with strain. And this will be followed by decrease in the systemic blood flow. The same for the right ventricle. The right ventricle is contracting against high pulmonary vascular resistance due to pulmonary vasoconstriction. Then the pulmonary blood flow will be decreased. This will be followed by decrease in the pulmonary venous return with the decrease in the left atrial volume, and also systemic venous return will be decreased with low right atrial volume, and the expected compensation for that is tachycardia. And then myocardial performance. If the left ventricle and right ventricle performance is impaired, tachycardia is the next expected compensatory mechanism, followed by pulmonary congestion, systemic congestion, dilated pulmonary veins with maybe pulmonary venous hypertension, and then congested dilated systemic veins. The expected early compensatory mechanism, as I mentioned, is tachycardia, and later on compensatory mechanism is congested dilated both ventricles, and the best example of that is dilated cardiomyopathy. As we see here in this impaired performance of the heart with dilated all of the heart chambers. Having only blood pressure is not enough to understand the underlying pathophysiologic mechanism of shock. If we know that blood pressure is directly proportional to blood flow, and we're using cardiac output as a surrogate marker for blood flow, multiplied by systemic vascular resistance. So if we know that the systemic vascular resistance is low and the blood flow is normal or increased, this is consistent with vasodilatory shock. High systemic vascular resistance together with low cardiac output is consistent with vasoconstrictor physiology type of shock. If both systemic vascular resistance and the cardiac output, both of them are low, this is consistent with cardiogenic shock. And when we assess blood pressure, we need to understand the physiology of the blood pressure components. So the systolic blood pressure reflects two things: systemic vascular resistance and the blood volume, overall body blood volume. And the heart performance will create a pulse pressure, which is a pressure above the diastolic pressure to eject the stroke volume. So the pulse pressure is typically reflecting the pump action of the heart and stroke volume. Both pulse pressure and diastolic pressure is the systolic blood pressure, sum of both of them. Then if we have low diastolic blood pressure below the acceptable for any given gestational age, together with maintained pulse pressure, and the systolic blood pressure might be decreased, secondary to decreased diastolic blood pressure, with increased stroke volume, increased heart rate, maybe cardiac output also might be increased at the end, with low calculated systemic vascular resistance. This is consistent with vasodilatory physiology. And the most common causes of vasodilator physiology: septic shock or systemic inflammation, late onset shock in preterm infant, or secondary to suprarenal dysfunction. Medications like vasodilator medication, morphine, anesthesia, acidosis, either respiratory or metabolic acidosis, and also might be associated with HIE. As you can see here, the blood pressure variables, with the top line is the systolic, the bottom line diastolic, and the middle is the mean blood pressure, and the red area is the pulse pressure. Pulse pressure is maintained, but the trend of the three components is decreasing. And then after the start of vasopressor, the blood pressure improved over a short period of time. Then if we have increased diastolic blood pressure together with narrow pulse pressure or decreased pulse pressure, and also decreased systolic blood pressure secondary to decreased pulse pressure, stroke volume usually decreased with compensatory increase in heart rate and low cardiac output, with high calculated systemic vascular resistance. So this is typically consistent with the vasoconstrictor physiology. The most common Causes of vasoconstrictor physiology. Number one, failure of postnatal adaptation in premature infant. Post-BD ligation, post-EV malformation, embolization, pulmonary hypertension due to increased pulmonary vascular resistance, sometimes associated with also increased systemic vascular resistance, HIE, in particular after start of cooling, and then septic shock, although the most common mechanism in septic shock is vasodilator physiology. Then if we have decreased or low diastolic blood pressure, narrow pulse pressure, and low systolic blood pressure, together with low stroke volume, compensatory tachycardia, low cardiac output, and also decreased or low systemic vascular resistance, this is consistent with cardiogenic shock. Cardiogenic shock is expected in low prelude, failure of postnatal transition or postnatal adaptation, and usually following vasoconstrictor physiology, pulmonary hypertension, myocardial dysfunction, mechanical ventilation with high mean air pressure, progressive acidosis, overdose of inotropes, and prolonged arrhythmia. Prolonged untreated arrhythmia might be associated with cardiogenic shock. And as you can see here in this preterm infant, 25 weeks, day 1, with low blood pressure and lactic acidosis of 5 millimole per liter. The three components of the blood pressure decreased with very narrow pulse pressure, which improved after start of low dose of epinephrine. Then we have the question, what is the value of near-field spectroscopy in the detection of compromised autoregulation? We have this example here of cardiogenic shock, decreased all of the three components of the blood pressure with a very narrow pulse pressure. That was immediately followed by decreased cerebral brain saturation, as you can see here on the monitor, 52, below our acceptable level, which is 60%. If we have the decreased blood pressure followed by decrease in cerebral saturation, it means the autoregulation already compromised. If the blood pressure dropped with maintained normal cerebral blood pressure, it means the autoregulation is still active and still working. In this example, after treating the low blood pressure and compromised hemodynamics, the brain saturation improved back to normal. So as you can see, very narrow pulse pressure, and after treatment, the blood pressure improved after norepinephrine 0.1 microgram per kg per minute. We have published the centile values of the most important hemodynamic parameters, including left ventricular cardiac output, mean blood pressure, systemic vascular resistance, perfusion, cerebral oxygen saturation, and fractional oxygen extraction in this article for preterm infant less than 29 weeks. This is a blood pressure table that we are using as reference for blood pressure in preterm infants. So there's the first day of life values for systolic, diastolic, and mean. And for each parameter, we have the highest, which is 95th confidence interval, and the lowest, which is the 5th confidence interval, and then the mean. And we have the blood pressure values is specified as per week of birth, gestational age, starting at 22 weeks up to 42 weeks. And here you have the blood pressure values beyond the first day of life. For the post-conceptional age, started at 22 weeks up to 46 weeks. So this is for the post-conceptional or corrected gestational age. For example, if you have a baby born at 24 weeks gestational age, and now he's 2 weeks of life, then use the 26 corrected gestational age values. If you don't have the resources to monitor the blood pressure through invasive arterial line, then you can rely on non-invasive measurement, but you need to adjust the monitor to measure the blood pressure frequently. And that could be every 10 to 15 minutes in unstable infants until stabilized. As you can see here in this example, with the frequent non-invasive blood pressure measurement, the trend of the blood pressure is decreasing. So you need to look at the trend, either invasive blood pressure trend or non-invasive blood pressure trend over time. Here we have the hemodynamic variables in reference to the centile values for the given gestational age. If the diastolic blood pressure, pulse pressure, perfusion index, systemic vascular resistance, cardiac output, and cerebral oxygen saturation all are maintained between the 10th and the 90th centile, then we'll consider that as normal, stable hemodynamics. In vasodilatory shock, we may expect low diastolic blood pressure, normal pulse pressure, high perfusion index due to hyperdynamic circulation, low systemic vascular resistance, high cardiac output, and variable cerebral oxygen saturation according to the degree of compensation. And then in vasoconstrictor physiology, we may expect normal to high diastolic blood pressure, normal to low pulse pressure, low perfusion index, high systemic vascular resistance, low cardiac output, and variable cerebral oxygen saturation. In cardiogenic shock, we may expect everything to be at the lower end of centile values, low diastolic blood pressure, low pulse pressure, low perfusion index, low systemic vascular resistance, low cardiac output, and variable cerebral oxygen saturation according to the degree of compensation. In case of left-right shunt physiology, the most common scenario, left-to-right shunt through the PD in preterm infant, we expect the diastolic blood pressure to be low or low normal, wide pulse pressure, variable perfusion index, high cardiac output, left side cardiac output, low systemic vascular resistance, and normal to low cerebral oxygen saturation. In case of volume depletion, we expect normal diastolic blood pressure, low pulse pressure, normal perfusion index, low cardiac output, and high systemic vascular resistance as a compensatory mechanism, and variable cerebral oxygen saturation according to the degree of compensation. Now let us match between the different neonatal situations that might be associated with hemodynamic instability and the different pathophysiologic mechanisms. In preterm infant, during the early postnatal transition, vasoconstrictor physiology might be expected, followed by cardiogenic shock. Vasodilatory physiology might be also present, left-to-right shunt due to early PDA, significant PDA shunt might also be present. And then hypovolemic shock, although it is uncommon in absence of any evidence of volume depletion or volume loss. And then beyond the postnatal transition in premature infant, we may expect vasodilatory physiology secondary to suprarenal dysfunction, left-right shunt due to PDA, and then hypovolemic shock. Septic shock, the most common physiology is vasodilatory physiology, hypovolemic shock secondary to third space losses, vasoconstrictor physiology, although it is uncommon in septic shock in neonates. In HIE, we may expect cardiogenic shock due to impaired myocardial performance, vasoconstrictor physiology secondary to hypothermia, vasodilatory physiology secondary to significant acidosis, and then hypovolemic shock secondary to volume restriction. In IDM, the main mechanism is hypovolemic shock secondary to severe hypertrophy of the myocardium and the underfilling of the heart. In pulmonary hypertension, we expect vasodilator physiology, cardiogenic shock with impaired LV and RV performance, vasoconstrictor physiology, because systemic vasoconstriction might be associated with pulmonary vasoconstriction or increased pulmonary vascular resistance. Hypovolemia secondary to decreased venous return might also coexist. Post-shunt closure, like post-PD ligation, the most common mechanism is vasoconstrictor physiology. That's why we are considering Marinon as the most common used medication in this category. Hypovolemic shock we have to be sure that the filling after ligation is adequate, and then cardiogenic shock also might follow. Keep in mind that overlap between different kinds of physiology might also coexist. Now we need to consider the logical selection of medication according to the physiologic mechanism of shock. Vasopressors, including vasopressin or norepinephrine, make sense to be used in vasodilator physiology. In inotropic and vasopressor dual medication like dopamine or epinephrine makes sense to be used in cardiogenic shock or also vasodilator physiology, although we prefer to use a higher dose of this category in case of vasodilatory physiology. Inotropic and vasodilator in dobutamine and merinone might be considered in vasoconstrictor physiology or cardiogenic shock as well. Fluids should be used with evidence of hypovolemia or hypovolemic shock. Fluids as medication should be used under guidance of echocardiography until we be sure that the filling of the heart is recovered and the endodiastolic volume is back to normal. Steroids might be used in refractory shock or with evidence of suprarenal dysfunction. Now let us discuss the management of hemodynamic instability according to the underlying pathophysiologic mechanism. During post-natal transition in preterm infant, we may expect vasoconstrictive physiology, then dobutamine might be the make sense medication, or epinephrine if there is cardiogenic shock, norepinephrine or vasopressin if there is vasodilator physiology, and a non-steroidal anti-inflammatory drug if there is left-right shunt through the PDA. And the fluids should be considered only if there is evidence of underfilling of the heart or dehydration. We may consider 10 to 20 ml per kg during early postnatal transition, or 30 ml per kg beyond that. In preterm infant, beyond the early postnatal transition, vasodilator physiology is the most common mechanism, then norepinephrine or vasopressin. One of them is the expected logical medication to be used, or non-steroidal anti-inflammatory drug if there is left-right shunt through the PDA. Fluids indicated if there is evidence of underfilling of the heart. In septic shock, vasodilator physiology is the most expected mechanism. Then vasopressor should be considered. Then fluids if there is significant third space losses. Dobutamine in case of vasoconstrictor physiology. In HIE, we may consider epinephrine in case of cardiogenic shock, dobutamine in vasoconstrictor physiology, norepinephrine in vasodilator physiology. Fluids if there is evidence of underfilling of the heart. In infant of diabetic mother with hypertrophy of the heart, fluids is the only recommended intervention. In pulmonary hypertension, if there is evidence of vasodilator physiology, then vasopressor is the most common used medication. Then epinephrine if there is evidence of cardiogenic shock. Dobutamine if there is evidence of vasoconstrictor physiology. Fluids in case of documented underfilling of the heart by echocardiography. Post-shunt closure or post-PD ligation, dobutamine, or we may also use merinone. And in this situation, we have to be sure that the diastolic blood pressure is maintained with narrow pulse pressure and low capillary fill time. In this situation, we expect low cardiac output by echocardiography. Fluids might be considered if there is evidence of underfilling of the heart. Epinephrine in a severe situation when we have all of the blood pressure parameters are low. In this case scenario, we have a term infant, 2 days old, IDM blood pressure 52/38, mean of 46. Cardiac output is low, 95 ml per kg per minute. Systemic vascular resistance really high, 484. We consider normal systemic vascular resistance between 150 to 150 millimeter mercury per liter per minute. Perfusion index was 0.6, and the cerebral brain saturation was low, only 45%. So what do you think about the underlying physiology? Typically, there's vasoconstrictor physiology with significant volume depletion, as you can see in the echocardiography, very or significantly impaired filling of the heart. In this condition, the inotrope support is contraindicated. Just fluids should be considered. Sometimes we will consider beta blockers to slow the heart rate and give more time for filling. Another case scenario, preterm 27-weeker male, 2 days old, maternal preeclampsia, blood pressure 30, systolic over 19, diastolic mean of 24, cardiac output is only 47 ml per kg per minute, with systemic vascular resistance is high, 320 millimeter mercury per liter per minute, and with echocardiography fraction shortening of 20, perfusion index 0.3, and cerebral oxygen saturation of 50. So what's the underlying physiology? Typically, vasoconstrictor physiology with the high systemic vascular resistance and the impaired myocardial performance. In this case, dobutamine was started, and the heart performance improved with only 10 mics per kg per minute of dobutamine. If you have a condition of unresponsiveness to cardiovascular support, you have to think about the alternative intervention. For example, could be wrong medication, then you have to change your strategy or reassess for the typical underlying pathophysiologic mechanism. It could be high dose of inotropes, and then you need, instead of adding more medication, you might need to wean or discontinue the non-physiologic medication. Suprarenal dysfunction might be associated, then you might need to add steroids, and also could be missed cardiac pathology. You might need to consult pediatric cardiology for a full assessment. Now you may ask what the evidence behind the physiologic approach. We investigated the impact of integrated evaluation of hemodynamics using targeted neonatal echocardiography with indices of tissue oxygenation by near-field spectroscopy as a new approach. And we found that integrated evaluation of hemodynamics was associated with shorter time to clinical recovery in infants with compromised hemodynamics compared to the empiric approach, with less number of medications and less doses of cardiovascular support. You can get more details about the physiologic approach in the management of hemodynamic instability by reading this article. And by reading this article, the reader will be able to, number one, demonstrate the basics of hemodynamic physiology, to identify the categories of shock, then interpret centile values for blood pressure, cardiac output, systemic vascular resistance, and tissue oximetry in preterm infants if they have the ability to monitor the tissue oximetry by near-field spectroscopy. Then identify the logical medical support for different cases of hemodynamic instability, and then identify the mechanism of shock in the challenging neonatal conditions. As I started with 4 main objectives, I have 4 main conclusions at the end. For successful management of shock, you need to look at the trend of systolic, diastolic pulse pressures and other parameters before and after any deterioration or interventions. Compare the values to the normalized centile curves for the post-menstrual age. Integrate the blood pressure values with other parameters, including urine output, acidosis, mean airway pressure, fluid status, hemoglobin, oxygen requirement, and peripheral perfusion. Then change your formulated recommendation if there is no improvement or with any worsening after interventions. Thank you for your attention.